Good evening, respected seniors and my dear friends. We welcome you all in the sixth session of ISCN Journal Club. I am Dr. Tanmay Ghatak from SGPJMS Lucknow, and along with me is Dr. Raghav Gupta, who is from AIMS Delhi. We both are working as a club coordinator for this ISCN Journal Club. As you all know, this ISCN Journal Club is conceptualized by our respected President-elect, Dr. Ranbir Singh Taggi sir. It has a tagline that is simplifying evidence-based medicine to bedside medicine, so that we can practice and prescribe evidence-based medicine from bench to bedside. Our ISCN Journal Club objectives targets and dissects the recent practice-changing research article and enhances learning by imbibing these breakthroughs and ultimately homogenize the critical care practices in our country. With this sort of overview, I want to introduce our respected guides, Dr. Manish Bharti sir from Yatharth Hospital, Delhi. Hello, sir.
Thank
And
you, Tanmay. Tanmay, just in the interest of everybody who's listening, I'm no more associated with Yatharth. Recently, I've joined as an associate director in Indian Spinal Injury Center, which is in Vasant Kuj, Delhi. Thank you.
Okay. Nice
Please
knowing,
continue.
sir. And
Please continue.
Dr. Neeraj from AIMS Patna. I think he is today busy with some family issues. And both of you have done Herculean task by initiating this ISCN Journal Club, sir. Welcome, both of you. And our expert for this journey is none other than the doyen of research methodology in our country, Professor Rakesh Garg, sir from AIMS Delhi. It gives me immense pleasure to have you here, sir. Sir, Rakesh Garg, sir. Hello, sir.
Thank you, sir.
Welcome you, sir.
Thank you so much, sir. Thank you, sir.
Thank you, sir. Uh, um, our respected President-elect, sir, Ranbir Taggi, sir, I called him a few minutes back. He is in Vancouver. He already gave his blessings to carry on, so that we are, without wasting time, we are going into the studies. We have two wonderful studies today for presentation for dissection and critical appraisal. Both of them published in this year, 2025, and from intensive care medicine. Uh, First study is having 670 plus patient, and second study has 122 plus patient. Both are negative studies. So let's start with our first study, that is personalized driving pressure guided positive end-expiratory pressure in patients at risk of postoperative respiratory failure. That is improved 2 study, a multicenter, pragmatic, randomized clinical trial. And it is to be presented by Dr. Subham Das. He is senior resident in Department of Anesthesiology and Critical Care in AIMS Guwahati, and is to be mentored by my dear junior, Dr. Anirban Bhattacharya. He is assistant professor, Department of Anesthesiology and Critical Care in AIMS Guwahati. We welcome both of you. And as you all know, I am again warning that it is a time-bound exercise. Please finish it by 16 minutes, as discussed earlier also, so that we can do a healthy discussion till 7:30 and move to the next topic. Now over to you, Dr. Subham.
Good evening, dear faculties and my senior colleagues, as well as my juniors. Today, I'm presenting a case study, Improve 2 trial, which was published in Intensive Care Medicine. The topic of discussion is personalized driving pressure guided positive and expiratory pressure in patients at risk of post-operative respiratory failure. It's a multicenter, pragmatic, randomized clinical trial. So it was published in Intensive Care Medicine by author Emmanuel and Audrey and others. It was published in 2025 August. So coming to the background of this study, we all know post-operative respiratory failure is a serious complication after surgery with an incidence of 0.5 to 4% in the general surgery and up to 20% in high risk or emergency cases, particularly abdominal cases. So lung protective ventilation, we all know, has helped us in ARDS patients. So the dictum was that this lung protective ventilation will also help us to reduce the post-operative respiratory complications in all these surgical cases, emergency surgical cases. So evidence issues was that prior trials showed mixed results, especially regarding what should be the optimum PEEP levels. So driving pressure concept was there, which is defined as tidal volume divided by respiratory system compliance or plateau pressure minus P. So high driving pressure was linked to poor outcomes in surgical patients. So current consensus suggests that personalizing the PEEP by targeting the driving pressure would be a great outcome, would show great outcome, but strong trial evidence is lacking on surgical patients, leaving its clinical benefit uncertain. So, coming to the study objective and the hypothesis, the IMPROVE-2 trial was conducted to investigate the effect of using airway driving pressure to individualize the PEEP setting in patients at risk of postoperative respiratory failure. The authors hypothesized that a strategy of targeting airway driving pressure would result in a lower rate of postoperative respiratory failure or death compared to the usual care that we give. So coming to the trial design and the participants, the trial design was investigator-initiated, multicenter, pragmatic RCT. It was conducted across 22 hospitals in France, and the study period was between March 2021 to July 2022. Coming to the participants, that is the inclusive criteria, adult patients more than 18 years of age undergoing emergency open as well as laparoscopic abdominal surgeries, and the expected duration of surgery to be at least 2 hours. And the exclusion criteria were invasive mechanical ventilation for more than 12 hours prior to surgery, chronic respiratory disease requiring oxygen therapy, and BMI of more than 40 if there is an undrained pneumothorax or imminent death. So coming to the randomization and masking, participants were assigned in a 1:1 ratio to either each group, the intervention group and the control group, using an encrypted web-based system. So randomization was stratified by site, presence, absence of shock, as well as hypoxemia, that is PF ratio less than 300 at baseline. And regarding the masking, patients, research staff collector, assessor of clinical outcomes, and statisticians were unaware of the study group allocations. So coming to the intervention and the control groups, in the intervention group, that is the personalized PEEP, what they did first, they initial recruitment maneuver was given, which was 20 to 30 second breath hold at 30 centimeter of water airway pressure. After that, stepwise decremental PEEP trial from 15 centimeter of water was given until the driving pressure became less than 13, and the highest qualifying PEEP was chosen. And recruitment maneuvers were repeated hourly after ventilator disconnection or if compliance worsened, that is driving pressure became more than 13. And the control group, which was the fixed PEEP group, patients received a fixed PEEP of 5 centimeter of water without any recruitment maneuvers. And common to both groups is that volume control ventilation with low tidal volume, 6 to 8 ml per kg predicted body weight, and rate was adjusted so as to keep the EtCO2 between 35 to 45, and IE ratio was kept at 1:2, and FiO2 was adjusted for SpO2 more than 94%. So coming to the outcomes, the primary outcome was a composite of post-operative respiratory failure, which included failure to wean within 12 hours, reintubation, or curative NIV requirement within 30 days, and all-cause mortality in hospital at 30 days. This was the primary outcome. And secondary outcomes were many. They individualized components of the primary outcome and severity grades of post-operative pulmonary complication, duration of mechanical ventilation until first extubation, total time to successful tracheal extubation, days alive and free of mechanical ventilation at day 30, cumulative total duration of mechanical ventilation at day 30, organ failure within 7 days, AKI, sepsis or septic shock at day 30, days alive outside the ICU at day 30, and duration of ICU stay as well as hospital stay. These were secondary outcomes. And tertiary outcomes were patients who had hypoxemia, pneumonia, ARDS, ventilatory associated adverse events, mechanical power, and 90-day mortality. So coming to the statistical analysis, this trial had 90% power to show, used 90% power to show an absolute difference between the groups 10% in the primary outcome measure at the two-sided alpha level of 0.05. And they assume 10% mortality rate of and 15% post-operative respiratory failure at 30 days. So total 10 plus 15, 25% for the primary composite endpoint. So the sample size came out to be 680 participants and 340 in each group. So coming to the study results. So 845 participants were assessed for eligibility, out of which 138 was not recruited. Most of the patients, 38, had severe chronic respiratory disease. That's why they were excluded. And then 707 were randomly assigned to 353 allocated to intervention and 354 allocated to control. In the intervention group, 15 were excluded, and in the control group, 13 were excluded. It is quite less. And then finally 338 were included in the intention to treat analysis in the intervention, and 341 in the control group. So baseline variables, the characteristics of the patients at baseline and the surgical procedures were well balanced between the trial groups. Open surgery accounted for 74.6% in the intervention group, and in the control group it was 77.4%, and it was comparable. Mean age in the intervention group was 60 and in the control group was 59. And ASA physical status was also comparable between the two groups. Most of the patients, almost half of the patients in both the trials had ASA 3. And also the factors which affect the respiratory system, like active smoker, then SOFA score, as well as PF ratio, all these were also comparable between the two groups. So the ventilator settings and the respiratory variables in the participants during the intervention period. So driving pressure was less in the intervention group, but the PEEP as well as the mechanical power was more in the intervention group. And the driving pressure and the mechanical power comparison was statistically significant. So we could see that PEEP as well as mechanical power was more in the intervention group. So coming to the primary outcome results, so 25.7% in the intervention group primary outcome occurred, and in the control group it was 20.2%. So absolute between the group difference was 5.5%, confidence interval minus 0.8 to 11.8. So relative risk was around 1.27, but p-value was 0.08. So it was not statistically significant. So interpretation was that individualized PEEP targeting driving pressure did not significantly reduce post-operative respiratory failure or death. So this was a time to event analysis also did not show a significant difference between the two groups with respect to the primary composite outcome. There was significant overlap between the control and the intervention. Coming to the secondary outcome, composite of reintubation or the curative NIV occurred more in the intervention group. It was 14.5% as compared to control, which was 7.4%, and it was statistically significant. Increase was mainly due to the higher use of curative NIV in the intervention group, and it was also statistically significant. However, the reintubation was also higher in the intervention group, but it was not statistically significant. So other secondary outcomes as well as tertiary outcomes, including the ventilator-associated adverse events, oxygen desaturation, pneumonia, ARDS, 90-day mortality, did not differ significantly between the two groups. So the central finding of this study was that individualized PEEP targeting the driving pressure less than 30 did not reduce the respiratory failure or death in high-risk abdominal surgery. And the unexpected outcome was that there was higher rates of reintubation as well as curative NIV in the intervention group. Unlike the previous study, which was eye-proof OLV, which was done in thoracotomy patients, showed reduced pulmonary complications while with a driving pressure guided PEEP strategy in thoracic surgery. They targeted the greatest compliance, selecting the lower driving pressure. This might be the reason why it showed better results in the eye-proof OLV. So why such unexpected outcome happened and the possible explanation in this study. So excessive PEEP. Highest PEEP was used to target the fixed diving pressure less than 13 centimeter of water. So there was possible overdistension and lung injury. And mechanical power, because the PEEP was highest, intervention group had higher mechanical power, and previous study showed higher mechanical power is associated with greater risk of respiratory failure and mortality. So alternative strategies like prior trials like iProve OLB, individualized PEEP by best compliance, selecting the lowest driving pressure rather than a fixed driving pressure, which also seems to be a more physiological approach rather than selecting the highest PEEP to target a fixed driving pressure. So strengths of this study was strong methodology. The methodology was well designed and it was multi-center RCT. Clinically relevant question, yes, optimal setting of PEEP during surgery was the question, and it was a pragmatic design, so it was applicable to the real world clinical practice, and pre-specified analysis, pre-published protocols and statistics analysis plan, including an intention to treat analysis was there, reducing the risk of reporting bias. So limitations, operating room team was not feasible to mask, and physicians deciding to wean also were not masked. And post-op support. Trial was intended to be pragmatic and did not include standardized criteria for prophylactic post-operative respiratory support, including the use of high-flow oxygen therapy after extubation or the NIV. Adherence to the protocol. 30% of the patients exceeded the driving pressure more than 13 centimeter of water. And the hemodynamic effects of the PEEP was not fully assessed, as well as the surgical body position during the surgery was not mentioned, was not recorded. Which may also affect the lung mechanics. And it is generalized to this limited surgical population who were undergoing only abdominal surgeries, lap and open. So coming to a conclusion, driving pressure remains an important parameter for lung protection, but targeting a fixed low driving pressure with high PEEP may cause harm, likely from lung overdistension. Further studies should evaluate patient-centered or individualized driving pressure targets, achieving the highest compliance rather than a rigid fixed threshold. So critical appraisal, study validity. Was the purpose of the study conveyed? Yes. In order to find the optimal PEEP by targeting a fixed driving pressure. Were the objective of the study clear? Yes. Was the study design stated and adequately discussed? Yes. Was the trial protocol and statistical analysis plan published before the enrollment? Yes, they published a protocol. Was there blinding? Operating room team was not feasible to blind, and physicians deciding to wean was also not masked. Where the baseline characters were similar, were quite comparable between the two groups. Was there a control population identical in all aspects? Yes. Respiratory parameters were also identical in both the groups. Possible bias? Yes, because the physicians deciding to wean was not masked. So there may be a possible bias there. And sample size estimation and power calculation adequate? Yes, it was adequate. 25% primary outcome composite was targeted and was kept at endpoint, and in the intervention group it came out to be 25%, and in the control group it came out to be 21% approximately. All the basic data adequately discussed? Yes. Outcome measures properly defined? No, because post-operative curative NIV requirement, what was the criteria, it was not mentioned properly. So dropout data, yes, they have given the dropout data. Adherence to predefined protocol? No. 30% of the patients exceeded more than 13 driving pressure. Study results applicable to local population? No. It was conducted in 22 hospitals of France. So demographics is different in our local population, so might not show all the changes. So these are the references. Thank you, sir. Thank you, sir.
Thank you, Dr. Subham, for this excellent and as well as concise talk right in time. I'll request respected Professor Rakesh sir to ask question or give his inputs, and simultaneously I'll ask Dr. Manish sir also to chip in.
So I think,
Yes,
yeah, Dr. Rakesh, please, sir. Dr. Rakesh is there.
yeah, he's there. He responded to. Manish sir,
Okay.
you start.
Yes,
Ah.
sir.
Now I can hear him in between. I think we're losing the signals in between. No problem, because I think Anirban is the moderator for this one, right? He's a mentor for this
Yes.
session.
Mentor,
So,
mentor.
Yes.
mentor, yes. Not moderator, yes. Moderator is only two, then Mohan Randhav, yes. So, Dr. Anirban, this is very interesting paper, and Shivam has done a lot of justice to when it comes to this paper. But can you just help us in understanding that how this evidence-based paper, you can use this evidence in the bedside medicine? So what are clinical pearls which we can draw out from this paper with respect to the ARDS
Yes.
or non-ARDS patients? Something like a quick snippet from your side.
Right. Right. So what I have understood from this study is that it is another bit of evidence that shows the difficulty of generalizing a ARDS lung protective ventilation into a non-ARDS patient. So far we have been failing to replicate good results of low tidal volume, high PEEP ventilation in non-ARDS population. If you remember, in 2018 there was a JAMA study, the PREVENT trial, which also could not show much improvement in clinical outcome with low tidal ventilation in non-ARDS population, because the lung mechanics is quite different between ARDS and non-ARDS. If you go through the baseline characteristic of this study, the mean PF ratio in the study cohort was 458. So none of them were suffering from ARDS. So I would not be too keen on using low driving pressure and high PEEP as a trade-off in non-ARDS subgroup of patients. Another study that comes.
Yes. Just to simplify for these students, will you endorse on the basis of the papers that low tidal volume should be given to all, irrespective of whether it's an ARDS, or don't recommend low tidal volume for the non-ARDS population?
Yes. So, I mean, there may not be much harm of using low tidal volume ventilation. Okay. However, we do not have evidence to support low tidal volume ventilation in non-ARDS patients.
So I think, would you like to share your experience, Raghav and Tanmoy? And then maybe in the next 2 minutes, I would like to reach it to a certain, the understanding which I have been able to drive from this paper.
Here also they have used 6 to 8 ml per, may I, sir? Mm-hmm. Here also, they have used 6 to 8 ml per kg. Around. To my mind, it is a bit high. 4 to 6 will be a good for lung protective, as it is universally said, no, sir?
Okay. And so you believe that low tidal volume should be given to all, irrespective of whether it's an ARDS or it's a normal healthy lung, right?
Basically, that is a lung protective ventilation strategy.
Great, Tanmoy.
That is the world is using.
So the world is moving for the low tidal volume. What about you, Raghav? What is your take? Because you are in AIIMS, and of course you must be dealing with a lot of operative patients. So what do you do?
Yes, so we do follow low tidal volume, but after going through a lot of studies, I'm not very sure that the same principles as Dr. Anirban also mentioned may apply to non-ARDS cases. So we need to explore that a bit. Still, we are following that only in our oncological patients, but I differ in that a little bit from my perspective.
No problem. The differences are always good because they help us in understanding. So if I have to just summarize, especially for these students, see, if you go by the ARMA trial, which was in 2000, we used to believe, and we have been proven beyond a doubt, that low tidal volume is meant for ARDS patient, right? So it is basically to be given for all patients who are having ALI ARDS. We have now changed the definition to ARDS, no more ALI, right? Till and the target was to keep the P-flat less than 30, right? This was the target from the ARMA.
Yeah.
But when we went to 2015, which was Emeto et al., he came with the understanding that low tidal volume is not always protective. In fact, higher tidal volume may not be always harmful. High PEEP, which otherwise seems to be very intuitive to choose, may not be always giving a benefit of mortality. And this was based on this Emeto et al. Study, which was done by Emeto and Slutsky, who are basically the pioneers in driving pressure. And they reached to the conclusion, if the rise in the tidal volume, if the rise in the airway pressures, they're not leading to an increase in the driving pressures, it is likely to be protective. And if increase in the PEEP is also leading to an increase in the driving pressure, then it is going to be harmful. So we reached to a conclusion from the low tidal volume to the P-flat that driving pressure is an important, crucial element which can help you in defining the safe ventilation for ARDS patient. Now, the same study almost has been quoted multiple times in the postoperative patients or the non-ARDS population. And to the best of my understanding, I may be wrong, but the same model has been replicated even in the non-ARDS patient, given the reason why, because it is not at least harmful. And the people have raised this as a concern that if you're giving them a conventional tidal volume, let's say around 8 to 10 ml per kg, then it does causes microscopic trauma. The cytoskeleton of the alveoli does get hampered, which is clearly get reflected by the rise in the biomediators, your interleukins, your cytokines, everything get reflected before it's going to get reflected in terms of the change in the oxygenation or the compliance. In other words, putting a patient on mechanical ventilation is like a mechanical power, which has a direct bearing to induce a trauma. So that's why, as Tanmoy has said, low tidal volume is always beneficial. Now the question comes how this population is different from the ARDS, non-ARDS versus ARDS. In ARDS, clearly we have taken off the recruitment maneuvers. We are no more doing recruitment maneuvers. It's taken off. But what was very interesting in this paper, which was shared by Shubham, is that they have tried RM. So if you actually go into the papers, the lung protective mechanical ventilation and strategy for the patients who are non-ARDS is defined by three things. One, you give them a good, your low tidal volume. You use recruitment maneuvers because the ZEEP otherwise is likely to cause alveolar de-recruitment. And the third is also to give them the PEEP on the higher side. Now, this has been conventionally drafted in the papers, in multiple papers. Now, interesting thing which Shubham has seen and which has shown that despite of giving this low tidal volume, recruitment maneuvers, and as well as giving an optimal PEEP has not done any justice. Now, that's why it's a negative study. So this is something very interesting. But before this paper, before this improved to trial, what I used to do for my post-operative or the perioperative patient, I used to keep them on low tidal volume. Recruitment maneuvers, which is a strictly no for the ARDS patient, used to be practiced in the perioperative patients. It is still being done by the anesthesiologist. And the third, the PEEP, we used to keep it on the high side. Driving pressure, we never used to measure in the perioperative patients. But although they have seen in this paper, I'm not very clear driving pressure, whether you can use it for the use in the perioperative phase as well. But it doesn't seem to be any harm. So that is what is my understanding and what is, I can reach it for the mentees. Low tidal volume, you should consider for all. Giving the driving pressures and keeping the driving pressures can be or should be considered less than 15, although this paper is not suggestive of any as such benefit. Giving them recruitment maneuvers, if it is a perioperative patients, can be justified, but certainly not for the ARDS patients. And giving an optimal PEEP, of course, should be done in careful titration as per the driving pressures. Anybody else who would like to share their views?
I have a couple of points.
Yeah, please.
So you have put it very nicely regarding what is the place of driving pressures. But there is something that we have to see in this study is that the difference in PEEP was 15 in the intervention versus 5 in the control. So you are not going to put 15 centimeter water PEEP in a non-ARDS patient with a healthy lung of 458 PaO2 FiO2 ratio. This is probably one of the fallacy of this trial because this is no more pragmatic. We never do that. Just as prophylactic 15 centimeter water PEEP, which was the median PEEP in the intervention.
Completely agree. But help me in understanding, Anirban, if your patient is on a laparoscopic surgery where intra-abdominal or insufflation pressures is going to be anywhere between 12 to 14. So do you think the transpulmonary pressures, which means the effective pressures across the lungs, is it going to be harmful? Now, this is what the next question should come.
Yes, right? Regarding the transpulmonary pressure, the transmission of transpulmonary pressure may not be, uniform. So towards the bases where, you may have increased alveolar pressure and atelectasis, the transpulmonary pressure may well be within the manageable range. But however, for a non-dependent areas, it may still be very high with a 15 centimeter water PEEP, right? So that is one way I would infer from it. And secondly, another thing is that this increase in PEEP indeed led to reduction in driving pressure in this group of patients, however, did not translate into mortality. So this also reinforces our understanding that PEEP is an essential element of mechanical power that we should not discard. And whenever PEEP leads to reduction in mechanical power, that is a welcome PEEP. Whenever PEEP leads to increase in the mechanical power, we should be very careful in going high up with that PEEP. Another interesting, just 1 minute I'll take. There was a study where they dichotomized the ARDS patients based on the data from major RCTs, and they have seen that a more severe ARDS, it makes sense to target driving pressure in more severe group of ARDS, whereas they have seen that driving pressure could not play much of a role as compared to respiratory rate when the PF ratio was high. So maybe the severity of ARDS also has a role to play while targeting driving pressures. So this is something
true. I completely agree with you. Yeah. So do we have Dr. Rakesh now? Or no, beautifully expressed, Anirban, that there's no doubt driving pressure role has been established in ARDS. The question is that whether we can take this driving pressure to the next level. So now we believe that, the ARDS is a man-made disease as well. So your poor ventilation, if you're giving not so correct tidal volume, can also induce ARDS. Right. And so the whole idea is to take it to the next level. So driving pressures, transpulmonary pressures can we extrapolate to the healthy lungs? That is what the question is coming about. And as per what I can understand from this paper, what Shubham has elucidated, as of now, we don't have extraordinary evidence to suggest it's going to be beneficial, right?
Yes.
I think they have used airway pressure. They have not used transpulmonary pressure or any serial manometry. That is also a fallacy. So I'm summarizing it to individualize high PEEP by driving pressure target is not helpful or not reduce the post-op complication or may even harm. So summarizes the first study. I think it is 7:30, so we'll go for the second study. Dr. Raghav, please.
Yes, thank you, Dr. Tanmay. So I would like to welcome the second team led by Dr. Pratibha. She is the consultant intensivist at Manipal Hospital, Bangalore. And the topic will be presented by Dr. Mridula. She's an associate consultant at Manipal, Bangalore. So over to you, Dr. Pratibha and Dr. Mridula.
Good evening, everybody. Can we see the screen?
We can see, Mridula. Please go ahead.
Okay. First of all, thank you for all the speakers for a wonderful first discussion. Now going on to the second topic. So we're going to be talking about early versus delayed catheter drainage for patients with necrotizing pancreatitis and early persistent organ failure. So this is the timing trial, which was published in Intensive Care Medicine in 2025 by Lukey et al. So coming to the introduction, we all know that severe acute pancreatitis is a life-threatening condition with a mortality rate ranging from almost 13 to 35%. Most of the times, severe acute pancreatitis can get complicated by either acute necrotic collection, which is less than 4 weeks, or if it is beyond 4 weeks, it can get walled off into a walled-off necrosis. So the current consensus regarding the intervention for these complications are mainly the consensus states that delaying the invasive interventions until the fluid collections mature, till a walled off necrosis occurs, typically more than 4 weeks, to allow for encapsulation. This may reduce the procedural morbidity. All the current guidelines mention this. So what was the reason for the authors to undertake this study is that for a specific group of patients with acute necrotizing pancreatitis and those with early persistent organ failure, the standard practice of delaying intervention could be actively harmful. So what they hypothesize is that those with persistent organ failure, the organ failure could actually be driven by the necrotic collection itself. The necrotic collection itself could possibly release the inflammatory mediators and toxins, and it can also cause a raise in the intra-abdominal pressure, and it can cause further harm. So they hypothesized whether this early percutaneous drainage in such a high-risk population, whether this could interrupt this process. So the ultimate goals was that, physiological goals at least, was that whether it was possible to remove the source of inflammation, decompress the abdomen, and thereby reverse the entire course of the organ failure. So in this study, they used the trigger of they did not use the trigger. The common trigger which is used for percutaneous drainage is actually suspected or confirmed infection. But in this study, persistent organ failure was the trigger which was used. The traditional practice of delaying percutaneous drainage actually stems from previous studies which used open surgery actually. So the landmark Panther trial, which was published, it showed the superiority of minimally invasive percutaneous or endoscopic drainage when compared to immediate surgery. So even though this study showed that these minimally invasive techniques were safer, whether the 4-week delay should be strictly followed or whether early drainage can help. That was the main intention of the study. So the clinical question the authors had in this study was whether early intervention for acute necrotic collection could improve clinical outcomes in patients with necrotizing pancreatitis, those complicated by early persistent organ failure. So prior to this study, the authors conducted a small pilot study of 30 patients in 2018 to 19, mainly to assess the safety and feasibility of early percutaneous drainage. And they noted that it was safe with no increase in infectious complications, although there was no statistical improvement in the clinical outcomes. Coming to the study design, So this was a multicenter randomized controlled trial, which was open label. The study was conducted between March 2019 to July 2022, although for a brief period, for 6 months, it was suspended due to COVID. The study was conducted in 5 tertiary teaching hospitals in China, and the data was collected via web-based electronic system. And in this study, they also had a pre-recruitment training. The educational startup meeting at each participating site was done. And the main trial coordinator center ensured that the protocol compliance was achieved. So the population which was studied in this study was those with severe acute pancreatitis with acute necrotic collection and persistent organ failure. The intervention was early percutaneous catheter drainage. The control group was standard care with interventions only when the infection is present. And the outcome was mortality and/or major complications. The inclusion criteria which was included in the study was age more than 18 to 70 years, confirmed diagnosis of acute pancreatitis, a CT diagnosis of acute necrotic collection, and the fact that the collection has to be accessible via percutaneous drainage, and also confirmed persistent organ failure. So the organs which were taken were respiratory system, cardiovascular system, and renal system. This organ failure that had not resolved by 7. So this is the primary inclusion criteria which they included. So once the patient fulfilled these criteria, then they assessed that during the second and third week, if they met any one of the following criteria, whether there was new onset organ failure, which was not present on day 7, and whether the organ failure persisted beyond day 7, and whether there was aggravation of the organ failure from that on day 7, as assessed by modified Marshall or SOFA score. So they excluded those with pregnancy pancreatitis, chronic pancreatitis, tumor-related pancreatitis, and already those who had drainage or surgery before admission, history of CPR, and those with severe comorbid conditions. So the randomization was done via block randomization with varying block size, and a computer-generated randomized sequence with sealed opaque envelopes were used. It was an open label study. However, the outcome assessors and the statisticians were blinded. So this is the consort diagram. So all the patients with the necrotizing pancreatitis were included, and out of that, 411 were excluded due to not meeting the inclusion criteria. And ultimately, 120 patients were randomized. Those who went to the early intervention group were 63, and those who went to the standard group was 57. Out of the 63 patients in the early group, 2 did not receive allocated intervention. And out of those in the standard group, 1 did not receive the allocated intervention. There was no patients who were lost to follow-up or who had a discontinued intervention. So the primary methodology was that those who were randomized to the early intervention group, image-guided percutaneous catheter drainage was performed within 24 hours after randomization. The catheter size was 12 to 16 French, and multiple catheters could be used. And they did a daily audit of the drain output and they removed the drain when it was less than 50 ml per day, or there was no suspicion of infection. And in this group, endoscopic drainage was not allowed initially. In the standard care group, interventions were delayed until suspected or confirmed infection was there, preferably more than 4 weeks from the disease onset. And in this group, either percutaneous or endoscopic intervention was allowed based on the site preference. So how did they define infected pancreatic necrosis? Was that either a positive culture from fine needle aspiration or index percutaneous drain, or gas was seen on CT. After first 2 weeks, persistence of inflammatory markers was also considered. And the rest of the general treatment was according to the international guidelines. So in this study, the primary outcome was a composite of major complications and/or death during the initial hospital admission. So how did they define the major complications? Was that new onset organ failure, whether there was bleeding requiring intervention, GI perforation, or fistula requiring intervention. The secondary outcomes during the hospital stay included individual components of primary outcome, organ-free days at 21 days, intra-abdominal pressure at 21 days, incidence of infected pancreatic necrosis, sepsis, splanchnic vein thrombosis, pancreatic fistula occurrence, and procedure-related complications. And the secondary outcomes was at 90-day follow-up, which was ICU-free days, hospital-free days, and 90-day mortality. The statistical analysis, it was based on their pilot study. In their pilot study, they saw that 50% of the standard care participants were expected to have composite primary outcome. So they took an anticipated treatment effect of 25% absolute risk reduction. So with this, 120 patients were required to achieve a power of 80%. The primary analysis was done with using an intention to treat protocol, and they also did a per protocol analysis. So a generalized linear model was employed to compare the group differences. They also adjusted for priori confounders, including age, sex, BMI, SOFA score, and CTSI. Analysis was performed using SAS 9.4. And they also had a pre-specified subgroup analysis, which included age, sex, hypertriglyceridemia or non-hypertriglyceridemia, and extent of pancreatic necrosis and CTSI. Coming to the results of the study, so you can see that the median age in this population was 43 in both the groups, and the sex, BMI, ET was all similar. One of the important things you have to highlight here is that the etiology of the pancreatitis is predominantly hypertriglyceridemia in their population, almost 54% in both the groups. And the interval between onset of acute pancreatitis and randomization was 9 days in the early intervention, and also 9 days in the standard group. The severity of illness was similar between both the groups, and the average CTSI median CTSI in both the groups was around 8. The predominant organ failure was respiratory, followed by renal and cardiovascular. Most of the patients in the early intervention group were on mechanical ventilator and had renal replacement therapy. Coming to the primary outcome, death or major complications during index admission, you can see that in the early intervention group, it was 33%, and in the standard group, it was 36%, with a confidence interval of -20 to 13.6. And the individual components, which included death, major complications, and new onset organ failure, death was 22% in the early intervention. In the standard group, it was 19%. Whereas major complications was higher in the standard group, that is 31%, and new onset organ failure was slightly higher in the standard group. Rest of the organ failures, as well as the bleeding and the GI perforation, was similar between both the groups. There was none of these parameters were statistically significant. Coming to the secondary outcomes, again, death at 90 days, there was no statistically significant difference. The infected pancreatic necrosis in the early group itself was almost 50.8%, and in the late group it was 42%. Here, one more important point to highlight is the occurrence of pancreatic fistula in the early group was almost 22% when compared to the 14% in the delayed group. The hospital-free days was also similar. The interval between the disease onset and the initial intervention, so in the early group, this was 9 days, and in the delayed group, it was 17 days. In the early group, almost 96% of the population received a percutaneous drainage, and in the late group, only 40% of the patients received a percutaneous drainage. Rest of the other endoscopic drainage, minimally invasive debridement, all of them were slightly higher in the early group, however, not statistically significant. One of the most important points here to be noted is that almost 56% of the patients in the delayed group did not eventually require any invasive intervention, and they got away with conservative management. So this is a graph which shows the organ-free days alive and mortality. Again, you can see that there is no significant difference between both the groups. This is the subgroup analysis. In all the subgroup analysis, there is not much of a difference. There is a slightly tending towards benefit in early intervention in those with higher CTSI, however, not statistically significant. When compared to this is the adverse events occurring during the trial. This was statistically significant in the early intervention group. These adverse effects included a range of non-specific events, including cardiac, vascular, gastrointestinal, and miscellaneous adverse events. Coming to the discussion, so this was a multicenter randomized trial which compared early intervention versus delayed care in necrotizing pancreatitis with early persistent organ failure. So this study showed that early image-guided percutaneous drainage did not reduce the composite primary outcome. And also one more important point is that in the standard group, almost 50% of the patients improved without any intervention. So the results do not support the original hypothesis that an early intervention could improve outcomes in this high-risk group. So this important study has to be compared with the previous study which was published called as Pointer trial, which was published in 2021 in NEJM. So they did early, again, it was an immediate versus postponed drainage. But here in this trial, when they included the patients was that when there was an infected pancreatitis basically. So even in this trial, there was no benefit from immediate drainage. And they also noted that almost 35% of the patients were successfully treated only with antibiotics without any drainage requirement. However, few differences between this study and Pointer is that in Pointer, they had recruited milder cases. Only 20% had organ failure. In this sicker patients were included in this trial. And the indication was mainly infection in Pointer trial. And the timing was that immediate, that was in the Pointer trial, immediate also meant a median of 24 days when compared to the 9 days in our trial. Despite these differences, both trials support guideline recommended delayed intervention. So there's a previous meta-analysis which mostly consisted of low-quality observational studies, which found that early drainage, which is less than 4 weeks, was associated with statistically significant increase in mortality. Whereas these two major RCTs, which Pointer and priming trial, did not show any difference in mortality between the two groups. And the possibilities could be the cons of an observational study, which could be that they probably had sicker patients to begin with. And the best interpretation is to combine both the findings. That the RCTs show definitely no benefit when compared to a routine early drainage, but observational studies do show a benefit of possible harm. I mean, do show a potential for possible harm. So these are all the major trials which are done regarding drainage in pancreatitis. These include the Panther trial, which was mainly particularly in step-up approach. And they noted that surgical approach had major complications and death significantly. And Penguin trial, which noted endoscopic necrosectomy was much better than open surgery. And in the Tension trial, the endoscopic step-up approach was slightly better when compared to the percutaneous approach. Lesser complications was noted in that. And the Pointer trial, as we already discussed. So the strengths of this trial is that it's a randomized multicenter trial. They had a very relevant clinical question and they chose the sickest of the patients in whom possibly there could have been some benefit. And they also conducted a pilot study prior to this study. And they had a pre-recruitment training as well in the participant sites. There was no loss to follow up. All the patients were completely followed up. And they did a sensitivity analysis with per protocol as well. So the data is robust. And the treatment for the rest of the patients were they followed the international guidelines. The limitations of that study is that mainly they have assumed a significant effect size. So they assumed a 25% absolute risk reduction, which is very high in a critical care study. So this could have caused underpowering of the study to detect more modest differences. And definitely the cons of using a composite primary outcome, this will limit the interpretability. And they have included cases irrespective of whether there was infection or not. Almost 50% of the patients had infected necrosis. So mixing this could have diluted the effect. And in this population, mainly 54% of the patients had hypertriglyceridemic pancreatitis. So this could as well limit the generalizability because in our population, it's mostly biliary. And the timing of intervention was also not significantly different. In the early group, it was 9 days, and in the delayed group, it was 17 days. So it was a delay of only 8 days. Coming to the critical appraisal, did the study address a clearly formulated research question? Yes, the PICO was very clearly defined. Was the assignment of participants to the intervention randomized? Yes. Were all the patients accounted for? Yes. Were the participants blinded? No, only the assessors and the statistician was blinded. And were the study group similar at baseline? Yes, they were similar at baseline. Did each study group receive the same level of care? All the standard care was similar in both the groups, but the interventions were slightly higher in the early group. And were the intervention reported comprehensively? Yes, the power calculation and all was appropriate, although with a high effect size. They have mentioned all the confidence interval. Did the benefits outweigh the harm? No, there was higher incidence of pancreatic fistulas in the early group. Can this be applied to the local context, especially with a high hypertriglyceridemic pancreatitis? Possibly not. So will this study change our practice? No, this will not change our practice, and this aligns with the current guidelines that recommend for delayed intervention. The most important contribution of this study is that it provides a robust evidence, being an RCT, against a plausible and an incorrect therapeutic path. So the key take-home messages are that early percutaneous drainage in those with persistent organ failure did not reduce any major complications. Nearly half of the standard care patients improved without any intervention. And so there is basically no evidence for early drainage to improve the outcomes. Thank you.
Thank you, Dr. Mridula and Dr. Pratibha, for a wonderful presentation and sticking to the timings. So I would like to begin with Manish, sir. So any feedback from your side? Interesting study, a lot of limitations, but yeah, a good take-home message.
In fact, thank you, Raghav. I really loved your presentation, Mridula. Extraordinary effort, and must congratulate to Dr. Pratibha for mentoring this study which you have taken up. So I just want to understand, do we have Dr. Rakesh? Because last time also we missed him. In case if Dr. Rakesh is there, I would like him to take the call first. Is he here? No.
He is there in the
group,
webinar, but I'm not sure whether he's able to connect or not.
Achha, no problem. So Dr. Pratibha and Dr. Mridula, can you help me in understanding that what was the intention of, although you have given a very elaborate picture, but I fail to understand that what was the intention behind early drainage which they want to achieve in a patient with acute necrotizing pancreatitis? What was the intention? So is it the organ dysfunction? And what was the reason for this organ dysfunction? How does it going to get benefit by? What was the mechanism of this organ dysfunction which they believe can get better by providing percutaneous drainage?
Yeah, they hypothesized before starting this trial was the infection or the inflammatory responses and the mediators which can be accumulated in the pancreatic cyst or thing that can worsen the organ damage, and it can lead on to multi-organ dysfunction was one of the criteria they thought. And to prevent this perpetuation of this process into multi-organ failure and adding on to mortality, they wanted to prevent at the early stage itself. That's what, and it can also be a contribution to increase in the intra-abdominal pressure was one of the pointer they were attributing to the mortality of acute pancreatitis initially when they have ANC. So to prevent all this, they thought early intervention might be beneficial. But then we already had a previous trial which was similar to the present one, which was pointer, which was already mentioned by Mridula, which didn't show any benefit by intervening too early also.
Okay, thank you, Dr. Pratibha. What I understand from Mridula, which she has declared in her presentation, that the aim of the early group was never with respect to the infection. It was basically of, so if infection we are not settling, let's say that we don't expect infection to happen in the first week anyhow, right? So the purpose is basically, which I'm not able to capture it, but maybe it's related to the raised intra-abdominal pressures, which they are trying, because you said new onset organ dysfunction. Now in pancreatitis, one of the commonest complications which we are going to see as a sequelae intra-abdominal hypertension and maybe an abdominal compartment syndrome. Because that is the only putative benefit which I can see as far as, the early intervention group is considered, because infection was never the consideration for them.
Yeah. So the intra-abdominal pressure in both the groups, even after putting the percutaneous drainage, was actually similar. So,
okay. So what was the reason, Mridula? So that is what, we have to understand, because infection, you said, they were not proving infection. So we just did it empirically?
No, they did before taking the patients into the trial, they did do an FNAC needle testing and look for any infective pathology like gram staining they had done.
That is for the late group, na, Pratibha? That is for the late group. Or is it like for the early group? For early group, as far as I understand, for the less than 2 weeks, they did it without any as such.
Anybody who had persistent organ failure was included, sir.
Anybody who has organ failure.
So what was the hypothesis which I understood is that now there is an acute necrotic collection which is there. So how sure are we whether it's causing any harm or no harm? We don't know. So whether it is triggering an SIRS response, whether that itself is the cause for this persistent organ failure, and
irrespective of sepsis or no sepsis, right? Irrespective of infection.
And one more thing they have mentioned is that somebody who is having significant organ function in the first 2 weeks, it is very difficult to distinguish between that organ failure versus an infection. So they will have all the signs of an SIRS with worsening organ failure. So again, it is difficult to differentiate between infection versus what is causing this organ failure. So that is why
Just a point.
So
Post randomization 9 day
Tanmay, just
yeah,
30 seconds, 30 seconds. So did they mean that new onset organ dysfunction, they have taken it as a sign of possible infection?
possible.
Which they want. Okay.
They
Yeah,
don't
please,
know
Tanmay.
what this
Possible, but they
ANC
clearly say it is more to do with organ dysfunction rather than infection.
Exactly. That's why I'm saying, Pratibha, because I'm not very clear at what was the intention of draining when the intra-abdominal pressure is not high. We know by all the means, by all the evidence, that the infection is less likely to happen. Anyhow, they're not proving infection in the first 2 weeks, which we're not expecting anyhow. So what was the intention of putting up a drain, which I can understand? Maybe they want to reduce the SIRS load by draining the necrotic foci and maybe the raised intra-abdominal pressure. So these are all the common plausible explanation that they wanted to resort to. Sorry, Tanmay, you wanted to ask, please.
Sir, absolutely. They have done it post randomization 9 days. That does not mean ki it is post pancreatitis onset 9 days, to my point. And so, to my understanding, so that means maybe more than 2 weeks we are draining it, and there is a chance of sepsis, and as well as persistent organ failure they are citing. That means maybe IAP related organ issues. These are the two areas. As an intensivist, our main target will be source of sepsis removal of the source of sepsis, citing it as a necrosis, and maybe most probably it is the cause of sepsis, and obviously such.
New organ
So it
dysfunction,
is
yes.
So it is.
But actually,
maybe
they have
hardy.
randomized anyone with an onset within 7 days of the acute pancreatitis with acute necrotizing collection. So they have not actually, of course, the intervention was 24 hours after the randomization, but then which was within first week only. It was not at second or third week. So as clearly Manisha was mentioning, it is more to do with organ dysfunction or IAH rather than the infection.
It is
Another
more,
one thing.
It is more like we don't know what is triggering this significant organ dysfunction in the first 2 weeks. So we have a source there. So whether that could be triggering the SIRS response and the organ failure. So that is why they.
Just to carry forward, Mridula, what was the output on an average daily basis for the patients who were having this PCD, percutaneous catheter, in the first 2 weeks?
300 to 400 ml.
300 to 400 ml. And any specific reason why patients with acute edematous pancreatitis were not taken up? Only the patients with the acute necrotizing pancreatitis, because still major of the fraction is 60 to 70% is acute edematous. So they have specifically taken up A and C patients. Maybe because maybe because acute necrotizing pancreatitis patient, they have more incidence of complication and their course is much more severe in comparison to acute edematous. Again, these were, see, I'm a great propagator of early source control. So I do a lot of early intervention. Now the counterintuitive things. Yes. Yeah, this is what I realized.
We all do, all intensive.
Yeah. In fact,
but not in pancreas.
We promulgate this practice that the source control is pivotal before you manage, any other things. But it's taken as one of the part of your sepsis bundle, right? Yeah. And this is what you have shown, Mridula, that even in one of the paper in 2021, so early source control is not helping them, right?
Yes.
So will there be an optimal intervention window, kind of things? Optimal intervention window may be there. Maybe 4 weeks.
So I personally what I've realized. Yeah, please continue them. Then I will say.
There must be some laboratory or cytokine panel or procalcitonin mediated some signs that
can help you in deciding.
There is a 9 day, yes.
Yeah,
for
I got your
drainage as
point.
well.
So
intervention window.
Again, it is a debatable point.
And one more thing is not palatable to me, not difficult to deglute, that even 56% of the delayed group is improving by its own without drainage. That is against my belief.
So in the pointer trial, where they included patients specifically with infected necrotic pancreatitis, in that as well, even 36% in the delayed group did not require any intervention. So it is very difficult to characterize like when to do the intervention or not.
That means source control itself is questioned.
Another important thing which I learned from this presentation which Mridula said the most common organ dysfunction which they were having is a respiratory, right? And that was the intention. So somewhere I still feel that maybe we have to extrapolate and maybe we have to introspect this paper as well, that maybe this was related to the raised intra-abdominal pressures which they were targeting. Because if you see the commonest reason why the respiratory system should get affected is because of the raised intra-abdominal pressures, apart from maybe atelectasis and maybe in some subset if you're having an ARDS. Pleural effusion will not lead to so much of morbidity, but in case, so that is another one, food for thought, which I want to. Another important thing you said, it has not made any difference whether you're doing early or late. What was the fluid strategy in them? So was it conservative or was it, the liberal? The reason why, because does it has any bearing as far as the outcome with respect to, because the patients who receive the right level of hydration, they have less incidence of complication in terms of, the pancreatitis sequelae. It's only when you're doing over-aggressive or overzealous. So does it have any bearing with respect to the fluid strategy, or it has been completely concealed in this paper?
In this trial, they have not specifically mentioned. So they have just mentioned all international guidelines were followed for general care. So they have not shown.
In the same essence, and role of antibiotic as well. Which antibiotic the group first early intervention group is getting, and which antibiotic the delayed group is getting. That is also a point to be noticed.
Early group, Tanmoy, we don't recommend because see, the problem is that we should not use antibiotics for the related to the pancreatitis. But if you have any hardware,
second, third week, it is second week, fourth week. You're doing a fourth week drainage, and then also you'll think, some antibiotic must be going on.
Yeah, so you're right. Antibiotics. You have mentioned it. Intra-abdominal pressure.
This one changes in intra-abdominal pressure during the first 21 days after randomization. There is slight reduction in the IAP in the early intervention group possibly over 7 to 14 days.
But does it has reduced the organ dysfunction in case if the patient is early intervened?
No.
So no reduction in the organ dysfunction.
Harm.
Yeah, she said about fistulae, pancreatic fistulae, she said. Okay. Still it is like a Pandora box for us. Abdomen has been always Pandora box. You don't know what's going to come next. Yeah. So Raghav, would you like to share some of your insights? Because
yes, so the conventional approach has already been discussed, is that obviously we'll be going with the late interventions, but definitely this paper has at least brought an insight for all of us to think about it, that whether we should be changing our practice or we should be going in the same direction. So that's from my side, sir.
So the main...
If we do, Mridula, because you are an expert, sorry, I'm asking you more question because you did extraordinary presentation. Let's say the patient is more than 4 weeks old and the patient has collection, which is infected. Should I drain or should I not?
Sure. Again, it depends on...
No, the reason why, because at the end we have to simplify the subject because it should not become confusing. What I can learn from your, the presentation, one, pancreatitis is basically a medical disease. Be conservative in your approach. Of course, the fluid strategy is important. By doing any invasive intervention, it's going to be not so beneficial, maybe possibility of harm, right? But let's say now there is a proven infection, 4 weeks old, acute necrotizing pancreatitis, I can see the gas.
Yes,
unless if the patient is not clinically deteriorating or if the patient is holding, probably we can wait and watch. It's not like just because they have a walled-off necrosis sitting there and without troubling, I think we can still wait.
No, walled-off necrosis, Pratibha, along with the gas. So just a
gas is emphysema of pancreatitis. You have to open it. You have to go for surgery.
With the gas,
there is no doubt in it.
Infected.
There is no doubt in it.
Infected, huh?
In emphysematous, you have to intervene.
Yeah.
No.
So basically, emphysematous, you mean to say sign of infection, right? This is what you're saying.
Yeah. Infection plus air, some bacteria is...
this is what I'm saying. Because if you have a gas, it's a suggestive of infection, secondary infection, right? So, but this paper has not given us any answer in this aspect.
And
But
in
this
Indian
Only
setting,
mentioned about early intervention, whether it's going to be beneficial or not. They in fact told that it's not going to be beneficial. And
Okay.
secondary outcomes are
Rather
mentioned,
harmful.
probably it might be causing harm.
Yes.
But the most
Un-
important limitation is sample size, I feel. So they have taken a huge 25% reduction in mortality. So possibly there can be some benefit which is maybe of lesser,
Underpowered.
but
And
can't
interesting,
say.
it is from China as well.
It was China.
and another
But the
And,
pointer trial,
uh,
which was done in the Dutch group, which was published that was also with a similar outcome.
Similar result. Yeah.
So I
One
think on the
one
important
basis of
important finding.
please, one by one. Pradula, you were saying something. Please complete.
all the guidelines which have come till now regarding intervention, all of them are based on observational studies. The main RCT which came first was the pointer trial that included infected early versus late. So this RCT definitely, even though it was a negative RCT, it provides a robust evidence and a level 1 evidence that there is no benefit of doing an early intervention, even though there is persistent organ failure.
Late intervention? We don't know.
It is a very, very important RCT with a negative outcome.
Okay. So Raghav, yes, please.
Just
late
one last
intervention was
point.
nearly half of the. Oh, sorry.
Raghav,
Yeah.
please.
So just one last point, sir. In Indian setting, they had already mentioned about the cost-benefit analysis also they did. So that also has to be taken account for the Indian perspective, that when we are doing early interventions and it is costing to the patient and the family members, are we really thinking about it?
Very important. Yeah,
Actually,
please.
Actually, the point that half of the patient we are intervening delay, and that is spontaneously improving. That is a catch point, key finding in this study, I can say. So I think
by the end of this presentation, Mridula, although it was phenomenal, Pratibha, but I'm more confused rather than having an answers. So I have to go back and I have to study more about pancreatitis management. I'm really helpless. So our apologies to the mentees, who are listening. Maybe it's another new thing which they should understand, that pancreatitis has been always very, very enigmatic, very charismatic in terms of its medical management, understanding, and the sequelae. Yeah, Tanmoy, you want to close it?
And my 2 cents is, please hold your horses before you intervene pancreatitis patient. Even with acute necrosis collection is there, please wait for a week or so. Is my 2 cents. So thank you. I think it's all done, sir. Thank you, Team Guwahati and Team Bangalore, for the wonderful, insightful presentation. Thank you, dear expert and guides, and all who have joined and watching this. Your blessings, encouragement, and loving warmth is needed towards this ISCCM General Club, and making this dream project of our President-elect very successful and glowing. Long live ISCCM. Thank you. Jai Hind.
Thank you, Tanmoy. And I must, have a lot of praise for you, Tanmoy and Raghav, that this edition which has been done is one of the best, especially the way Pradula has presented the data. So this was very, very insightful, very detailed presentation, and that too in a time-bound fashion. So I think we all should learn from this episode, that how we have to carry forward the journey of General Club. So I must congratulate you. Very well executed.
We are thankful to guide and expert as well. Both are the negative studies, and both excellently presented, and we are very happy that it's a very successful General Club.
Thanks to Shubham and Anirban as well.
Thank you, Manisha.
And we are going to meet every third Friday, right? Every third Friday of every month. And of course, so we will continue this journey, and a very heartfelt gratitude to the ISCCM, the President-elect, Dr. Ranveer Singh Tyagi, for keeping up with this activity, which is elaborating and which is giving us actually the real taste of how you can use evidence-based medicine to the bedside medicine. And that is where the power lies. Thank you.
And improving our knowledge as well.
Yes. Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, Pratibha.
Good night.
Thank you, sir.
Good night.